All right. Hello, everyone, and welcome to this month's Clinical Corner, where we are going to be discussing wandering and elopement and how to manage those things, some of the regulatory pitfalls. Recently, there has been I would say, a rash of citations and at high level scope and severity around wandering elopement, which triggered us to kind of want to take advantage of an opportunity to discuss some of the specifics around that. So, in today's session, we are going to talk about the differences between wandering and elopement, some facility policies. We're going to talk about interventions and care plans. I also want to touch on emergency preparedness, as well as some best practices in general. Today, I don't have anybody monitoring the chat. So, at the end, I will take questions. So, you can go ahead and throw them in there, and I'll discuss them at the end when we have an opportunity. So, to get started, let's talk about understanding wandering. Definition of wandering is defined as random or repetitive locomotion. That movement may be goal directed, for example, searching for something like an exit, or non-goal directed wandering may be aimless, requiring a response to address potential safety issues. We often see wandering in secure residential units in order to have that be a safe space for them. So we might see goal directed and also just aimless wandering in those situations. Implications of wandering, non-goal directed wandering could indicate potential issues such as frustration, anxiety, boredom, hunger, or depression. And goal directed wandering might be utilized to fulfill certain needs for exercise or what I most often see as sensory stimulation. Both types of that wandering will require an assessment of what that looks like and supervision to address potential safety concerns that come up out of it. Hence the reason that doing wandering assessments are important. Talking about some safety concerns in wandering, there's physical hazards that can occur. Wandering can become unsafe when residents enter an area that is physically hazardous or contains potential safety hazards such as chemical, tools, and equipment. And if any of you on this call have ever had a mock survey process with myself or my team, you will know that we often talk about items that are labeled keep out of reach of children. So those things can be anything from like air fresheners down to cleaning chemicals, and even certain over-the-counter lotions and topical products like that can be labeled keep out of reach of children. And from creative surveyor standpoint, if you provide care for residents who might be at risk for wandering or elopement or have dementia, may not understand safety risks around that and they would have access to those items, that becomes a safety hazard being able to access that. Another area where I often see, access to chemicals is unlocked bathing and shower rooms because we should be cleaning after residents use those areas. And oftentimes, staff will leave those cleaning chemicals, those sprays out and accessible. And if that door is unlocked, unattended, and somebody with wandering or dementia may be able to get in there, the thought process is that they might drink that product or potentially use it on their skin, spray it in their eyes. So it's really important that we take into consideration keep out of reach of children items and have a safe place for them. I also want to discuss that more in depth in terms of like if you have residents who love having their room sprays or they want to have their own cleaning products and those kind of things, or even those who love to have like Hall's cough drops on their bedside. Those are all things that we really need to encourage residents to keep stored away out of sight, so that other residents who may be at risk for wandering and going into those spaces wouldn't be at risk for harm from ingesting or using them inappropriately. There is also a risk of altercations when it comes to residents who wander. So you might have residents that enter into other residents' rooms, leading to an altercation or, again, contact with hazardous items, increasing risk of potential injury. It's not just entering into other residents' rooms, it's entering into other residents' perceived spaces too. So that can be sitting down at a table where somebody has kind of territorially taken over a spot in that space, or even just brushing up too close to somebody else in their wandering behaviors. So those are all definite risks. And there's also a potential for increased fall risks. So when you have unsafe wandering associated with a resident who is wandering consistently, getting overly tired, and then potentially stumbling and falling, that presents an additional risk. And, nobody loves to do all the things that come with falls that happen in facilities. So there's definitely safety concerns in wandering, and this is not an all comprehensive list. This is just really highlights of things that we often do see. So we can talk briefly about alarms and supervision because there are facilities that utilize wander guards, motion sensors, those types of alarms. So wander guards and motion sensors can help monitor a resident's activities and provide alerts to staff about potential wandering incidents. That being said, staff also have to be vigilant in order to respond to alarms in a timely manner because they don't necessarily replace supervision. And a few of the 2567s that I've reviewed in the last 3 months have had elopement incidents where alarms were going off and staff were not responding, and that caused an issue. So the importance of staff education and seeing how staff respond to those alarms and ensuring that that actually occurs timely to prevent any kind of issues is really important if your facility uses alarms as a method to provide increased supervision. Another important piece of any kind of alarm usage, whether it's wander guards or it is motion detectors or it's door alarms, scheduled maintenance and testing of those alarms are essential to ensure proper functioning and reliability. So if your maintenance staff does not have alarms on their list of things to be checking on a regular basis, then that would be something, you definitely want to check into to make sure that that occurs on a regular basis. So different facilities have different expectations for the timeliness of that. There is no specific regulation that says when those alarms needed to be checked. I can tell you that, like wander guards, the general idea is that we check placement and function of the actual device. If it's placed on a resident or on their wheelchair or walker, that's checked Q shift. The actual wander guard system at the doors that maintenance is also checking that functionality. Ideally, it would happen every day, but a weekly basis would be great. And any other device that you're utilizing for that kind of alarm additional supervision, just make sure that you have some kind of setup, a system for checking it, and that it is done regularly and documented so that you all can have that as support for any potential issues that might come up. Effective supervision can absolutely mitigate risks associated with wandering, ensuring resident safety and well-being. All very important pieces to this puzzle for sure. So we got to talk a little bit about elopement and why that's different. So elopement is when a resident leaves the premises or a safe area without the facility's knowledge and supervision. And this situation poses a risk to the residents' health and safety, exposing them to hazards like heat or cold exposure, dehydration, and other medical complications. Elopement can lead to severe consequences such as limb or life loss related to weather exposure, burns, drowning, or being struck by a motor vehicle. And unfortunately, all of these situations have occurred related to elopements. So, talking about elopement versus wandering, wandering again is random, could be repetitive locomotion, which may be goal directed or not goal directed. And elopement is specifically referring to leaving a safe area without supervision, increasing risk significantly. While wandering can indicate needs for like exercise or stimulation, elopement represents a critical safety concern. So this brings us to facility policies for elopement, which also should be closely aligned with your emergency preparedness. So first off, around this is assessment of risk. Facility policies should clearly define the mechanisms for assessing or identifying residents at risk for elopement, ensuring that staff can effectively monitor behaviors and situations. In that, once you've done an assessment, if you have somebody who is mildly at risk or highly at risk, a care plan absolutely needs to be developed and implemented. So we have to be utilizing our assessments to inform the care plan, and then those care plans need to be communicated well out to the staff who are providing care. Monitoring procedures, we need to implement monitoring procedures such as regular check-ins, observational rounds. It could be that we're going to do the wander guard, or maybe they're a candidate for a secure unit. Whatever the situation is, we have to have an intervention in place after our assessment for people who are identified at risk. The other piece about assessment is that it's not just a one and done situation. We are going to assess residents on admission, generally quarterly, and change of condition. Management strategies as part of your facility policy should include interventions in each of their care plan, like we discussed, and the potential for elopement, focusing on individual needs and triggers. Emergency protocols. So this is where I was talking about. We kind of corresponds with that. The facility's disaster and emergency preparedness plan must include a plan to locate a missing resident, ensuring that all staff are trained and aware of the protocol. So let's talk specifically about some interventions and care plans for residents at risk of elopement. You want to implement individualized monitoring strategies tailored to each resident's behavior and risk level. Regular assessments can help identify those who may wander or elope. Recommend conducting assessments on admission, quarterly change of condition. And then also, it is a recommendation that I give to all facilities that I work with that if you do have a resident that has an elopement situation, that after that incident, really very closely after, that you do a new assessment to capture that situation. So don't wait until the next quarter if there has been an incident related to eloping. You're going to want to look at your environmental modifications that may need to be addressed, such as securing exits, creating safe wandering areas to reduce the risk of elopement while still providing freedom of movement if they're more on the wandering side and not actively just trying to leave your facility because they don't want to be there. You're going to want to develop clear, comprehensive care plans that include the specific interventions for the residents at risk, addressing both safety and emotional needs, and care plans should be updated after any incident of elopement with a new intervention. This is really important. Really important. Please, if you take anything away from this, if there is an incident, you have to ensure that there is a new intervention to try to prevent that incident from occurring again. If the resident has families or responsible parties that are involved, you're going to want to engage those people in the care planning process, providing education to them about wandering and elopement behaviors, and really promote a collaborative approach for what is the best case scenario for that person. State reporting guidelines. We got to talk about this just briefly. So, reporting requirements for elopement incidents in nursing homes vary by state, and they establish specific guidelines to ensure resident safety and regulatory compliance. Some states mandate reporting as soon as an at-risk resident even crosses a building's threshold, while other states have different reporting requirements that the patient has to be missing for a specific period of time. Some are 8 hours up to 24 hours. It's very different by state. So you need to be aware of what your state reporting guidelines are in terms of elopements and what you have to report for an occurrence. Right. We're going to talk briefly about emergency preparedness for missing residents. So, you have to have a plan for locating missing residents in your disaster and emergency preparedness manual. That plan has to clearly define the mechanisms and the procedures for assessing, identifying, monitoring, and managing residents' risk for elopement, and then ensure that actions are taken swiftly to minimize the risks associated with residents leaving a safe area without facility awareness. Generally, that includes staff sweeping the building and having a process for making sure that like everybody understands that we checked all the rooms on A hall and somebody else checked all the rooms on B hall and somebody was doing a sweep of the outside of the facility, and then how that gets communicated and where that centralized location for who's managing that emergency preparedness operation. Another really important piece that I think a lot of people miss is that we're not often doing annual elopement drills really well. So I think this is really an important piece to add to your just planning for the year for emergency preparedness drills. It's not just fire drills, definitely would add in an elopement drill at least annually. And then if you have a large turnover in staff for whatever reason, because sometimes that happens, that you wouldn't wait for the next year, that you would make sure they get the education and training, and then we do a drill to kind of get everybody up to speed. If your facility uses elopement binders, and what I mean by elopement binders is that at your front desk, maybe there is a binder of residents who are noted to be at risk for eloping or wandering, that you would keep a binder with their face sheets and maybe a larger picture for them. So in the case that they did leave and you needed to quickly get information to the police, that you would have that at your disposal, that binder needs to be updated frequently, and somebody needs to be responsible for that, updating that binder, and they need to understand that that's their role and what frequency that needs to be updated. A lot of times when I do mock surveys, I ask for elopement binders and it isn't updated for several months, or there's been changeover in the social services staff, so nobody knew that they had to pick that back up. So this is really an important. Not all facilities that I go to use elopement binders, but if that is something that you do, you're going to want to make sure you have a process in place to manage that. If you do, unfortunately, experience an actual elopement event with one of your residents, I highly encourage that you use that as a learning exercise for emergency preparedness and document accordingly. What I mean by that is that you evaluate staff's response to that elopement event, how they handled it, what were any pitfalls, you run it through QAPI, and use that as one of your two required events that you have to do. So you either have to do a tabletop or an actual event to meet emergency preparedness requirements. So if you do have that as an event, please make sure you run it through QAPI, look for your root cause analysis and all the things, and capture that response on your QAPI notes as well. All right. So let's talk about some recent case studies that have come up in because I do review regular 2567s on a monthly basis for all over the United States. So here's a couple that have come up that I thought were going to be good to talk about. So these are failure statements directly from 2567. So the first one says, despite resident number one's exit-seeking behaviors and successful elopements from the facility within 11 days of his admission, the facility failed to reassess the resident's elopement risk and implement interventions to prevent the resident from again eloping from the facility. So everything that we just talked about earlier, and when I talked about if you have an actual event, that you make sure you do a new elopement assessment so that you can update that resident's risk. Because one of the worst things is you do an initial assessment, the resident's fine, nothing's really they're not trying to leave, no issues. And then they do try to elope or get out, and we don't do a new assessment so that your initial assessment shows no risk and everything's fine, which is an inaccurate reflection of a resident who had an actual event. So again, if there is an actual event, you're going to want to make sure you go through all the things. A lot of people will use a risk management report for elopement for the purpose of ensuring that all the notifications are completed, notifications to the patient's physician, their resident responsible party member, that there is a root cause analysis portion of that you can assess for any injuries in that, and that we have a new intervention identified and care plan updated. So I do recommend that if you're not doing elopement events as part of your risk management process, like you would with falls or choking incidents or any of those kind of things, that this is included as well. The next one is that the facility failed to provide adequate supervision for resident number 3, who was assessed to be at high risk for elopement, had a history of exit-seeking behavior, resided on a secure memory care unit, had a wander guard to prevent elopement. That resident followed dietary staff through a secured memory care door, traveled through the facility, and eloped through the front door without staff knowledge. Resident number 3's wander guard alarmed, as it was supposed to, at the front door when he exited. However, staff failed to timely respond and further failed to adequately investigate the source of the alarm upon response. So again, this is one of those things as management that I think it's very important that if you hear an alarm going off, that you are out on the floor seeing how staff respond. That we do education and training to make sure that they're not just alarmed out and that's just part of the noise, the background noise of the facility. We really want everybody in the facility to respond to those incidents because of the high risk of complications if they were to get, like I said, get hit by a car, be exposed to the elements, that kind of thing. It really is a critical issue, and all staff need to be on board with addressing any of those kind of alarms. The other piece of it is to make sure that not only are staff educated about going in and out of memory care unit doors, but that family members are also educated about making sure that nobody's going to follow them out, that they are not inadvertently just letting people through doors on accident. So the third case study is the facility failed to prevent an elopement and cameras were reviewed, identifying that a resident had put the code into the door to open it and disable the alarm when he exited the facility. So this is more specific for those of you who do have secure memory units. If you do have a door code, do you have a process in place for changing the door code? If you have a resident that's maybe a little more cognitively intact and can see the numbers that you might write at the top of the door jamb, because I've seen that all over the place too. I'm not condoning that as a way to remember numbers by any stretch, but I do know that some facilities do that. So how are we ensuring that residents aren't accessing that code and utilizing it to get out of the facility? So is maintenance changing it? How does that information get communicated out to the staff and to the family members when door codes do get changed? And then how do we just make sure that residents aren't accessing that information and using it to get out when they're at risk? So I'm going to recover kind of like everything in a nutshell for the basics. So first, assess risk upon admission, quarterly change of condition. Make sure you have individualized intervention. So this can mean engaging residents in structured activities, personalized interventions that reduce exit-seeking behaviors, such as providing purpose-driven tasks or modifying the environment to reduce triggers. Can include supervision and monitoring. So this might mean that we have to assign and document increased supervision for residents identified as high risk, including the potential for visual checks at center intervals, maybe potentially using a wander guard or another system such as that, and that we have care planned accordingly based on risk. If you have if you have that scale for your guys' wandering risk that says they're high risk, medium risk, or low risk, if at any point in time in your assessment that it says that they are medium risk or high risk, I encourage you to implement a care plan. That should just go along with whoever is doing the wander assessments and however you guys manage your care planning process. I have seen multiple buildings where they identify somebody to be at medium risk and they only care plan if the person is at high risk. And I do know that there are some assessments that maybe might trigger somebody to be at a higher risk than what, really they're presenting as. And that is where the facility has a responsibility to document why we think they're a lower risk than what the assessment is saying and care plan that accordingly. Again, we talked a little bit about the binder, and if you have that, making sure that somebody is dedicated to updating it. Staff training and awareness, regularly educate all staff, including non-clinical, on recognizing and responding to elopement risks, including identifying exit-seeking behaviors. Have an immediate response plan that's developed and regularly reviewed. From an emergency preparedness standpoint, you guys are required to review your policies, your emergency preparedness policies on an annual basis. So that annual review needs to occur and be signed off on. It doesn't necessarily mean that you have to go in and sign off on every single policy that's within your elopement binder, but you guys do need to review it and make sure that it is fitting within your population and what works for your building. You also want to make sure that staff know their roles and responsibilities in responding to elopements. Again, I am a big fan of conducting elopement drills at a minimum with staff annually. And then you're also going to want to have collaboration with local authorities. So I encourage you all to establish relationships with your local law enforcement and first responders so they are familiar with the facility and the protocols for missing residents. In terms of environmental and safety measures, ensure your doors and exits are secured with appropriate alarms, delayed egress, or coded keypads as needed, while still maintaining compliance with fire and life safety regulations, and have a system in place to evaluate this routinely. If you use alarms and wander guards for the functionality, test and maintain your wander guard systems, the door alarms and surveillance equipment routinely to ensure they are functioning properly. Nursing should be checking wander guard placement functioning at least Q shift. Maintenance should check the wander guards on the doors daily. Outdoor safety. Evaluate and secure outdoor spaces, ensuring fencing is intact and pathways are designed to deter wandering beyond safe areas. In terms of family and resident education, inform families about elopement risks, the interventions that you have in place, and encourage their involvement in safety planning. Post-elopement analysis, conduct a thorough review after any elopement incident, update policies and care plans accordingly, and implement corrective measures to prevent recurrences. Ensure you run any elopement events through your next available QAPI, and if needed, do an ad hoc copy so that you can, if it's something that you had to report to the health department, you're going to want to ad hoc copy that before they're going to come out and investigate it. And the reason I say that is so that you can look at make sure you've done the root cause analysis, you've implemented interventions. We have all the things so that we can say we identified it first. We treated it like it was an actual citation. We basically wrote our plan of correction so that if they come back out to evaluate that situation, that we have a good solid plan and try to avoid a citation that way. Here's some basic wander risk assessment resources for you guys. If you, the Veterans Administration Toolkit is actually pretty cool. So I encourage you to look through that. I did include Briggs's wander data collection tool. I don't have any affinity one way or the other towards that one. Lots of different people use different tools. There's also the revised Algase wandering scale, the RAWS community version that is fairly appropriate. So I do know that you guys, a lot of you all use your own. I would just encourage that whatever tool you're using is that it's a valid and a reliably tested tool, and that it's appropriate for your facility as well. So now I will go ahead and open it up for questions and see if I can take anything on the chat box if you guys have it. Otherwise, thank you for joining me today, and I hope you found this helpful. For those of you, I will add this PowerPoint, we'll add the recording, and any other information to the calendar invite so you can access it there. All right. Any questions? I'll give it a few minutes and you guys can go off mute if you would like, or type in the chat box. Thank you guys for joining. I really appreciate it. I'll stay on until approximately 10:30.